Assalamu alaikum.
Walaikum.
Bismillahirrahmanirrahim. I, Dr. Muzdalfa Parvez, PGR Cardiology from Hayatabad Medical Complex, Peshawar. Today, I am going to present a case history. Excuse me. Okay. Today, I am going to present a case history of a 19 years old Afghani boy who presented with a complaint of the episodic exertional shortness of breath. He had episodes of the multiple time chest infection documented for the last 2 years. Otherwise, he has insignificant past family history and the past history. Initially, he had a first consultation with physician where he underwent certain investigations which include complete blood count which shows eosinophils up to 46.1%. Sorry, there is some misprinting. 46.1% and with increased level of the IgE antibodies. Stool routine examination was also done, which came out negative for the ova, egg, or any parasite. Bone marrow aspiration done, which shows 60% eosinophils. Gene study was done, which came out normal in that patient. At the time of the presentation, his ECG showed atrial fibrillation with a fast ventricular rate. On the basis of this workup, a diagnosis of the Loeffler syndrome was made and treated accordingly with corticosteroids and hydroxyurea, but unfortunately, he didn't improve. So he referred to us for the further workup, diagnosis, management, and especially to exclude the endomyocardial fibrosis. So we have done his echo, which is obviously the mainstay for its diagnosis. This is the apical four-chamber view. Here you can see the biatrial enlargement. This is the left atrium and right atrium, both are severely enlarged, and the small size LV cavity. And here you can see thickening of the endocardium, which is starting from the septum. Mainly it is involving the apex and then extend to the lateral wall of the LV cavity. And there is another pointer here. You can see the thickening of the mitral valve leaflet. This is the color Doppler image in the apical four-chamber view. And here you can see the mitral valve incompetency as well as the tricuspid valve incompetency with with mitral regurgitation and tricuspid regurgitation. This is this is the PW Doppler on the mitral valve, which is showing the large E wave and the small A wave. So the E by A ratio is 3.3 with the deceleration time is 108 milliseconds. So basically we have the grade 3 diastolic dysfunction in that patient, and E to E prime ratio is 26.1. So we have the restrictive cardiomyopathy at the end of the echo. For the better information about the anatomy of the patient and for the better tissue characterization, we have gone for the CMR. This is a clip of the CMR. Here you can see bilateral pleural effusion and the consolidation in the lung fields. This is the static image. Here you can see the enlarged right atrium, small size LV cavity, and the homogeneous thickening of the endocardium, which is mainly involving the apex. There is the obliteration of the LV cavity at the apex, and it is extending from the septum to the lateral wall. The one important feature in this case is the pattern of the fibrosis, because the fibrotic obliteration mainly involves the LV apex, and it is continues with the lateral valve involving the inflow path of the LV, and the outflow tract is preserved. This is the cine fourth chamber view, and this is the cine two chamber view. Here you can see the bilateral atrial enlargement. LA and the RA are severely enlarged. Small size LV cavity, tricuspid regurgitation, and mitral regurgitation. So the findings of the CMR, we have LV and diastolic volume is 93 ml, LV and systolic volume is 58 ml, and EF is 37%. LA area is 42 centimeter square, RA area is 43 centimeter square. Both are severely enlarged. And finally, we have the RV and diastolic volume 101 ml and systolic volume is 73 ml with the ejection fraction of 27%. This is the short axis cine view. Here you can see the abrupt obliteration of the LV cavity when we move from the base to the apex of the LV, and this abrupt obliteration of the LV cavity is one of the important features in the case of the endomyocardial fibrosis. And this is the LVOT film, and here you can see the large left atrium with mitral regurgitation. This is the static image, black blood image, and here you can see A band-like structure extending from the septum to the lateral wall of the LV cavity with a small cavity enclosing between the two layers. So this is basically the thrombus. So next we have the late gadolinium enhancement image of the patient. Here you can see the three-layered structure. The myocardium is exactly normal and then followed by the hyper enhancement of the endocardium, and then there is the overlying thrombus. So this is called the double V sign, which is a pathognomic feature in case of the endomyocardial fibrosis. And the hyper enhancement is extending towards the lateral wall when involving the inflow tract, but the outflow tract is preserved. You can see very properly in this picture. Okay, this is also the static image. Here you can see the hyper enhancement, which is involving only the apex. So let's come to discuss the endomyocardial fibrosis. It is actually a mysterious and the challenging cardiovascular disease which is characterized by the deposition of the fibrous tissue leading to the restrictive cardiomyopathy. In epidemiology, it has bimodal distribution peaking at 10 to 30 years with an equal distribution between male and females. It has a prevalence rate of up to 20% in Africa, America, and the Asia. And the long-term prognosis is very poor with the medical treatment. The mortality rate is around 75% in 2 years. The pathogenesis of the endomyocardial fibrosis is unclear, but various theories have been conducted which propose the following factors to be involved in the pathogenesis of endomyocardial fibrosis. The first one is the eosinophilia and the parasitic infestation, which can be due to schistosomiasis, filariasis, and malaria. These parasites are thought to be the potential triggers for the pathogenesis of the endomyocardial fibrosis, which can be demonstrated by the increased level of IgE antibody and eosinophilia, which was present in our patient. The next is the nutritional factors. Environmental factors mainly include malnutrition, poor protein diet, magnesium deficiency, cassava toxicity. Cassava is one of the carbohydrate source which is mainly used in the Africa because it is one of the cheaper source of carbohydrate, and the vitamin D toxicity. And the last but not the least is the genetic predisposition. The natural history of the endomyocardial fibrosis is divided into three phases. The first one is the acute form of inflammation. Second one is the transient progressive form. And the last one is the chronic phase. In acute form, the patient can be presented in febrile illness with pancarditis, eosinophilia, dyspnea, cardiac edema, eosinophilic infiltration, and fibrosis. In ECG, we can have the non-specific STT changes, conduction defects, arrhythmias like atrial fibrillation or ventricular fibrillation. Echo, you can see homogeneous patchy infiltrates in the layers of the cardiac walls. In next phase, which is the transient progressive form, actually there is a flare-up and recurrence of the active inflammation, which finally evolves and progresses towards the chronic phase. In the chronic phase, we have the three subsets of the presentation. Patient can be presented with the biventricular involvement, which is the most common presentation. Around 55% of the cases have the biventricular involvement, which is followed by the isolated RV involvement. It is around 28%, and isolated LV involvement is the most rare presentation, which includes only 16%. Patient can be presented with the pulmonary hypertension, congestive cardiac failure, conduction defects, blocks, arrhythmias, and pulmonary embolism. So for the diagnosis and assessment, we have the first modality, which is the optimal, and the mainstay for the diagnosis is the echo, which allows the optimal information about the morphology and the non-invasive hemodynamics. We have a criteria for the diagnosis of the endomyocardial fibrosis, which includes the major and minor criteria. In our patient, we have one major criteria and the four minor criteria, which is the obliteration of the right or the left ventricular apex with a severity score of 4. And in minor criteria, we have the restrictive flow pattern across the mitral or tricuspid valve, diffuse thickening of the anterior mitral leaflet, enlarged atrium with a normal size ventricle, and the thin endomyocardial patches localized to the one ventricular wall. So finally, we reach to the definitive diagnosis with the one major and the four minor criteria with a severity score of 4. And finally, we have the most ideal tool for the diagnosis and for the management is the CMR. It provides the additional values for the early diagnosis and assessment. It is an ideal tool for the monitoring the response of treatment and for defining an anatomic details. finally, we have the treatment options. We have both medical and the surgical treatment options. In medical treatment, symptomatic treatment for the heart failure by diuretics and the ACE inhibitors, anticoagulation for the intracardiac thrombi, and due to its strong association with the Loeffler syndrome, patient can be given corticosteroids and immunosuppressive drugs. And the surgical treatment, we have the open heart surgery for the resection and the valve replacement if required. So in short, we have the endomyocardial fibrosis, which is one of the most neglected disease of the poverty, which should be early diagnosed and managed properly. Thank you.
Thank you, Dr. Muzdalfa. Nice presentation.
It was really a nice presentation and very good pace and very well presented. थोड़े से कमेंट्स हैं यहाँ पर एक तो ये कि हमने यहाँ पर अभी रिसेंटली एक केस पब्लिश किया था जो अमेरिकन सोसाइटी ऑफ इको का जर्नल है केस उसमें पब्लिश हुआ है और वो जो है आपका जो केस है एक्चुअली इसमें जो सिनोफिलिया भी है तो ये लोफलर सिंड्रोम ज्यादा है और वैसे यू कैन हैव एंडोमायोकार्डियल फाइब्रोसिस इन द एब्सेंस ऑफ hypereosinophilia. So, but this is really a nice case and very well presented, and I appreciate the presentation.
थैंक यू डॉक्टर टीपू। यहाँ पर मुझे ये कि और भी ऐड करना है, ये तो जो है ना ये तो लाफलर एंडोकार्डाइटिस इसको हम लेबल करेंगे। इससे पहले मैंने एक पोस्टर जो है ना वो एसीसी में वो एक्सेप्ट हुआ था, दैट वाज प्योरली एंडोमायोकार्डियल फाइब्रोसिस और उसमें दोनों वेंट्रिकल्स इन्वॉल्व है। इसमें तो सिर्फ एलवी इन्वॉल्व था, एलवी एपेक्स, बट इन दैट केस बोथ द वेंट्रिकल्स or that patient actually he expired after 2 years of after the presentation. So he was basically a tablighi and he went to Africa and he bring this disease from there. तो ये जो है ना ट्रॉपिकल एरियाज का डिजीज है एंड इट इज ए रियल डिजीज, स्टिल इट इज मिस्टीरियस। बहुत सारे इसके फीचर्स जो है ना अभी भी एक्सप्लेन नहीं कर सकते हैं।
I think आपके पॉइंट्स बहुत अच्छे हैं। एक मैं सॉरी शबा सर एक कमेंट दूंगा। एक तो पहली बात है मुझे ऐसा फील होता है देयर तो डेफिनेटली है और हम ट्रॉपिकल कंट्रीज तक कह के रुक जाते हैं, लेकिन मैंने अभी जब से सीमांत करना शुरू किया है 2011 से तो उस वक्त तक मैं अभी तक 5 केसेस देख चुका हूं जिसमें से 2 जो थे वो आइसोलेटेड राइट वेंट्रिकुलर इन्वॉल्वमेंट थे और बाकी जो थे उसमें से 2 जो थे वो बाइवेंट्रिकल थे और एक सिर्फ लेफ्ट वेंट्रिकल था। तो इतना रेयर भी नहीं, आई थिंक वही बात हो जाती है कि हम इसको सोचें और एको पे अक्सर हम मिस कर देते हैं बिकॉज अफ्रीकल ऑक्यूपेशन जो हो रही होती है उसको उस तरह से अप्रिशिएट नहीं कर पाते और बहुत सारी दफा आई हैव सीन कि है ना हाइपरट्रॉफिक कार्डियोमायोपैथी के साथ लोग इसको मिक्स कर देते हैं एको पे।
ये बड़ी इम्पोर्टेंट बात है कि ये रेयर केसेस को हमारे स्टूडेंट्स को बच्चों को पढ़ना जरूर चाहिए। हम लोग उनको रूटीन में हर हफ्ते महीने में एक आधा वेरी रेयर केस दिखा भी देते हैं ताकि जब रियल लाइफ में उनके सामने आए तो वो पहचान सके। एंड रियली इन चीज़ों का पता हो तो बड़ी कीमती जानें बचाई जा सकती है एंड सेविंग अ लाइफ इज रियली वेरी इम्पोर्टेंट।